Is this a synchronous primary adult granulosa cell tumor, or is it a metastasis? This case was seen in a 60-year-old multipara who presented with a history of abdominal swelling. She had TBSO on account of bilateral ovarian lesion. So, synchronous primary adult granulosa cell tumor means independent, simultaneous development of granulosa cell tumors in both ovaries rather than spread from one ovary to the other. This is extremely rare. As we all know, most adult granulosa cell tumors are actually unilateral. When both ovaries are involved, metastatic spread is more common than true synchronous primaries. So here, let's look at the differences between synchronous primary adult granulosa cell tumor and metastatic spread from one ovary to the other. Definition: independent, simultaneous development of adult granulosa cell tumor in each ovary. Metastatic tumor from one ovary spreads to involve the other ovary. Frequency: synchronous less than 1%, extremely rare. Metastatic more common. Size pattern: synchronous, both ovaries may be similar in size. Tumor may be comparable. Metastatic, one ovary typically has a larger primary tumor, the other has a smaller deposit. Capsular involvement: in synchronous, tumors confined within capsule, no breach. In metastatic, often capsular breach. In primary site, tumor may involve surface of contralateral ovary. Histologic pattern: each ovary may have subtle histological variation independent of architecture in synchronous tumor, while in metastatic, histology in both ovaries is usually identical, mirroring primary tumor. Whereas here is about mutation status, peritoneal disease absent or minimal, no extra ovarian implant in synchronous primary, while in metastatic often present, peritoneal implants, ascites, or widespread disease. Vascular or lymphatic involvement absent in synchronous, while it's possible in metastatic. Staging: both ovaries stage 1A, if not surface involvement in synchronous, while it's at least stage 2 or higher due to metastasis in metastatic spread. Prognosis: better with synchronous, worse with metastatic. So let's look at the images now. So this is the video. This is the right ovary, which I see the left one, the left ovary, as you can see here before I play the video. Look at this low level echoes here, look at the papillary projections, and look at these irregular papulations here. So you can see that this one is a multilocular solid lesion here. You see that? You see the low level echoes here, the papillary projections. You can see the multilocular nature here. This is the right ovary, so this is the left ovary. So you can see that this is also a multilocular solid lesion. Initially I thought it was actually solid, but on review I realized it's actually multilocular solid lesion. Here you can see the fallopian tube here, the fimbrial end. So look at this lesion here. This is the bladder, this is the uterus. Now the anterior posterior symmetry here. Another small polyp here. Remember, adult granulosa cell tumor is estrogen producing. So now that you have a endometrial polyp here, a tiny one. Look at the fimbriae of the fallopian tube here. Protein in acidic fluid. You see that? Is the fimbrial end. So again, multilocular solids, variant 2. So both are multilocular solids, lesions, but the one on the left has more solid components than the one on the right. So they have similar phenotype, both multilocular solid lesion. So here is noting the vascular flow. Look at the vascular flow to the left ovary. These are aquatic vessels, Bilateral, as you can see. Okay, so look at the vascular flow to the left multilocular solid lesion here. Look at the vascular flow. Now moving to the right. These are flash artifacts. So not the larger lesion on the right side. So flash artifacts. So you see the papillary projection, and look at the blood flow to the papilla here. See that? So bilateral multilocular solid lesions. This has a color score of 3 to 4, while the other one has a color score of 2. These are aquatic vessels, Bilaterals. So you see the blood flow here is much more than the one on the right. So here you can see the right ovarian lesion, the left ovarian lesion, both multilocular solid lesions. Here you can see the presence of ascites. So this is a gross specimen seen at histopathological examination. So you can see this is a right lesion, it's bigger. This is the left lesion. But you can see the capsular rupture actually is from the left. The capsular lesion is from the left side of the lesion here. So it's possible that there is a primary lesion and this is the metastatic lesion. So now, what did the histopathology reveal? Uterine cervix unremarkable, uterine corpus unremarkable, ovarian mass, granulosa cell, tumor. So now let's revisit this and see whether this is actually a synchronous primary adult granulosa cell tumor or metastatic spread from one ovary to the other. You see this, one ovary typically has a larger primary tumor, but here I suspect there is a smaller one that is a primary because there is capsular rupture in the smaller one which is on the left side. So often capsular breach, yes, there is capsular breach. Yeah, histology in both ovaries identical, yes. Often present, that is peritoneal deposits, ascites or subcapsular disease. You can see ascites was present. Then at least stage 2, you can see this is more than stage 1. Here, of course, prognosis is worse here because of capsular rupture and presence of ascites. And of course, common lesions are commoner. So in all probability, this is likely to be a metastatic spread rather than a synchronous primary adult granulosa cell tumor. Thank you very much for listening.